So as we said, sometimes the intrinsic lung diseases, the diffuse parenchymal disorder reduce all lung volumes. So there is diffuse intrinsic parenchymal disease affecting the interstitial space, or there are debris of tissue are building up here and exudate. So in the setting of such a disease, the lung volume is reduced because there is an excessive elastic recoil in the lung. So the lung elastic recoil is increased very much. When the elastic recoil of the lung increases because of intraparenchymal lung disease, when there is an intraparenchymal scarring and the lung elasticity is increases, so the recoil of the lung increases. The lung recoil on itself. So the recoil, the inward recoil of the lung exceed the chest outward recoil, and this will reduce the lung volumes, prevent the lung from expansion in response to change in the volume. So the compliance of the lung in the setting of intrinsic lung diseases as a class of restrictive lung disorder is decreases. So for you to have a large change in pressure, you need a small change in volume. This is the setting of intrinsic lung disease as a class of restrictive lung disorder. Okay, so the relative increase of the lung elasticity to the outward recoil force of the chest wall lead to reduction in expiratory airflow, and this in a proportion to the lung volume. So we have a low lung volume, we have a low expiratory volume, we have a low proportion of the expiratory volume to the lung volume, we have a low compliance. So arterial hypoxemia in disorders of pulmonary parenchyma is primarily caused by ventilation perfusion mismatch. So these patients will develop hypoxia, and hypoxemia in these patients is due to mismatch between the ventilation and the perfusion. They are normal perfusion, but there is no good ventilation. So these are the alveoli, okay, and these are the blood vessels. So in the setting of parenchymal disorders here, perfusion is normal. The blood is flowing normally, but the air cannot be exchanged normally. So the perfusion is intact, normal, but the ventilation is affected. So ventilation perfusion mismatch will lead to reduction in the diffusion of oxygen from the alveoli to the blood, and this will lead to arterial hypoxemia, and this will lead to desaturation, sometimes at rest and sometimes only when the patient is in demand, exercise, I mean. So decreased diffusion of oxygen rarely contributes to hypoxemia because sufficient time still exists for full equilibration of oxygen and carbon dioxide. So yeah, there is a problem with the alveoli, so it cannot permit the diffusion of oxygen, but in the resting person, there is enough time for the oxygen and CO2 to diffuse, even though there is scarring in the tissues. So at rest, it will never occur. Arterial hypoxemia rarely occur unless the disease is very severe. But it occurs always when there is an intrinsic lung disorder and the patient is in demand, exercising, moving, consuming oxygen. So when you consume oxygen, more rapidly, and you need oxygen more rapidly, and there is no sufficient time to allow oxygen to flow in and carbon dioxide to flow out, so the patient becomes desaturated, hypoxemic, and hypercapnic. So this, I think, is enough for us to highlight the pathology and the pathophysiology with significant exercise-induced desaturation in the setting of intrinsic lung diseases. Intrinsic lung diseases, we said that there are 5 classifications for these diseases according to the cause and the etiology. So collagen vascular diseases and other like drug-induced pulmonary problems and unclassified or primary lung diseases, organic and inorganic dust exposure and environmental exposure, and idiopathic fibrotic disorders. Okay, so diseases like SLE, rheumatoid arthritis, scleroderma, polymyositis, dermatomyositis, ankylosing spondylitis. So rheumatoid arthritis and SLE, they are known autoimmune disorders. Scleroderma is an autoimmune disorder. Polymyositis and dermatomyositis. All these are autoimmune disorders. Some of them affect the joints and all the system of the bodies. Some of them can be confined to specific places, sometimes confined, sometimes systemic, like polymyositis and dermatomyositis. Sometimes can be presenting only affecting the muscles and skins, but sometimes can be systemic, sometimes can be non-secondary to malignancy, sometimes can be primary and idiopathic. Ankylosing spondylitis only affects large joints and and the central axial joints. So all these diseases are potential cause for intrinsic lung disease. Then we go for other causes like drugs. We have in the drug categories drugs like nitrofurantoin, amiodarone, gold, phenytoin, thiazides, hydralazine, bleomycin, and cyclophosphamide, methotrexate, and radiation. So the nitrofurantoin is an antibiotic that is used for urinary tract infection. Amiodarone is a medication that is used for arrhythmia. Gold is used for autoimmune disorders like rheumatoid arthritis. Phenytoin is an anti-epileptic. Thiazides is an antihypertensive, diuretic. And hydralazine is a vasodilator, antihypertensive. Other medications from bleomycin here are anti-cancer medications. So other causes are primary lung diseases, primary lung bronchial disorders that is unclassified like sarcoidosis, pulmonary Langerhans cell histiocytosis, lymphoangiomyomatosis, and pulmonary vasculitis, alveolar proteinosis, eosinophilic pneumonia, and cryptogenic organizing pneumonia. أصلا uh, it's known that respiratory diseases have many disorders that is named uh, have histological names like these disorders, like pulmonary Langerhans cell histiocytosis. It's a disorder where Langerhans cells accumulate in the pulmonary cells and causes interstitial lung disorders. Lymphoangiomyomatosis, which is angio uh, dissemination of leiomyoma via lymph and blood, so lymphangioliomyomatosis, which affect the lungs and cause interstitial lung diseases, pulmonary vasculitis, inflammation of the lung vessels, and alveolar proteinosis, accumulation of protein in the lung vessels, and eosinophilic pneumonia, accumulation of eosinophils in the lung and causing inflammation and destruction of the lung, and cryptogenic organizing pneumonia, which is cryptogenic means idiopathic, organizing means inflammatory and changing the structure of the lung. So these called primary unclassified lung diseases. One of them is also the sarcoidosis, which is well known, non-caseating granulomatous autoimmune systemic disease. Other causes are dust exposure, which is inorganic dust exposure, silicosis, asbestosis, talc, pneumoconiosis, amblyossis, hard metal fibrosis, coal worker, pneumoconiosis, and chemical worker lungs. All these occupational dust exposure may cause restrictive lung diseases and interstitial lung disease. So organic dust exposure like farmer lung, bird, bagasus lung, and mushroom workers lung, and humidifier lung, and hot tub pneumonitis. All these are workers working with the natural environment and exposure to birds' vomits and mushroom and hot tub pneumonitis. It's a pneumonia occurring in people who always go to the hot tub, like hot tub cellulitis, hot tub pneumonitis. So the idiopathic fibrotic disorders, they include acute interstitial pneumonia, idiopathic pulmonary fibrosis, usually interstitial pneumonitis, and lymphocytic interstitial pneumonitis, desquamative interstitial pneumonitis, and non-specific interstitial pneumonitis. So it's basically an interstitial pneumonitis, usually interstitial pneumonitis, which is causing the idiopathic pulmonary fibrosis. And the interstitial pneumonitis can be lymphocytic, it can be desquamative, it can be non-specific. So now we finished with the intrinsic disorders. We will go to the extrinsic disorders. Neuromuscular diseases of the chest wall in which kyphosis, non-muscular diseases of the chest wall in which kyphosis can be idiopathic or secondary because restrictive lung disease. The most common cause of secondary kyphoscoliosis is neuromuscular disease. So we can have an extrinsic lung disease that is non-muscular, which is kyphosis, means abnormal structure of the vertebra, and it can be primary. The most common cause of secondary kyphosis is neuromuscular disease, diseases that causes spasticity, like polio, muscular or muscular dystrophy. So non-muscular disease of the chest wall in which kyphosis can be idiopathic or secondary. So the most common cause of secondary kyphoscoliosis is neuromuscular disease like polio, muscular dystrophy. So other causes of extrinsic lung diseases as a part of restrictive pulmonary disorders, fibrothorax, fibrosis of the alveoli of the pleura and the chest wall, pleuridesis, and massive pleural effusion, morbid obesity, ankylosing spondylitis, and thoracoplasty. Other causes are neuromuscular diseases, such as respiratory muscle weakness, such as myopathy, myositis, quadriplegia, or phrenic neuropathy, problem with the phrenic nerve, inability to contract the diaphragm, and so on. So, fibrothorax, pleural effusion, any problem that affect the extrapulmonary structure, the extra lung structures, they are causes of extrinsic diseases. So fibrothorax, massive pleural effusion, obesity, ankylosing spondylitis, and thoracoplasty. Others are neuromuscular problems and neurological manifestations of neurological disorders. So here is a table. I hope it's clear for you. You can see it. It's classifying the lung interstitial disorders according to the lung response. So when we are talking about a lung response like uh, like alveolitis, interstitial inflammation and fibrosis. So alveolitis, interstitial inflammation and fibrosis. So we are talking about these factors. Some of them are known, some of them are unknown. So other response is granulomatous response, which is some of them are known, some of them are unknown. So it can be inflammatory response or granulomatous response. Causes of granulomatous responses are, some of them are known, some of them are not known, some of them can be systemic, some of them can be local, and other response is the granulomatous response. Part of it can be known, part of it can be unknown. So the known causes of alveolitis, interstitial inflammation, and fibrosis are asbestosis, which is an occupational exposure to asbestos, foams and gases, drugs like nitrofurantoin gold amide, radiation, aspiration pneumonia, and as a consequence of acute respiratory distress syndrome, which is a disease that occurs in severe sepsis and critically ill patients. Smoking related can be desquamative interstitial pneumonia. So smoking can cause primary lung disease, unclassified interstitial lung disease like desquamative interstitial pneumonia, like respiratory bronchiolitis, like Langerhans histiocytosis. So these are caused by smoking. So unknown causes: idiopathic interstitial pneumonitis, connective tissue diseases, pulmonary hemorrhage syndromes, which is Goodpatcher syndrome, and pulmonary alveolar proteinosis, lymphocytic infiltrates, eosinophilic pneumonias, lymphoangiomyomatosis, and amyloidosis, or it can be genetics and inherited, like tuberous sclerosis, neurofibromatosis, Niemann-Pick disease, which is one of the uh, inborn error of metabolism, Gaucher disease, and Goodall syndrome. Gastrointestinal or liver disorders like systemic disorders like Crohn's disease, primary biliary cirrhosis, all of them are autoimmune disorders, and graft versus host disease. So these are the unknown causes of interstitial pneumonia, interstitial inflammation, fibrosis, and alveolitis. And why we say that they are unknown? Because they are they have vague presentation. So when the patient present with these conditions, you cannot put them, you cannot you cannot get them from the history directly unless you are meticulous in considering them in your thorough evaluation of the patient history. Then you confirm and deconfirm using investigations. So, and also another reason why we call them unknown, because most of the classified patients as idiopathic, they have one of these disorders. So lung response as granulomatous have known causes like hypersensitivity pneumonia, which exposure to organic dust, and inorganic dust like beryllium and silica. So they cause granuloma. Asbestos causes inflammation, while silica causes granuloma and beryllium causes granuloma. You have to differentiate. You have to know which dust causes granuloma, which dust causes inflammation, which disease causes granuloma, which disease causes alveolitis and interstitial pneumonia. So sarcoidosis is causing granuloma, granulomatous vasculitis, Wagner granulomatosis, bronchiogenic bron bronchiocentric granulomatosis, and lymphomatoid granulomatosis. So a granuloma is that centered in the bronchi, or granuloma that is more associated with lymphocytes. And so these are the occupational and occupational exposure to organic dust and inorganic dust. So where we find the inorganic dust, we find it. We have the nature of the respiratory response here. We have the comment here. So our comment is here. The nature is here. So asbestos is an inorganic dust. Silica, coal dust, beryllium, and others. So the respiratory manifestation of asbestosis is fibrosis, pleural disease, and cancer. Asbestosis causes mesothelioma. Silica causes progressive massive fibrosis, silicosis, cancer, increase the risk of tuberculosis because it inhibits neutrophils, chronic obstructive pulmonary diseases, and coal dust causes fibrosis, progressive massive fibrosis, and COPD. Acute pneumonitis occurring in patients with borreliosis, along with lung cancer, which is highly suspected, and others can cause acute pneumonitis to lung cancer and asthma. Okay, so the asbestos is famous by mesothelioma, the beryllium highly suspected lung cancer, the coal dust and the silica characterized by progressive massive fibrosis, and the others are acute pneumonitis. All the other organic dust causes chronic obstructive pulmonary diseases. Some of them causes asthma, some of them don't, but if they don't cause asthma, they cause asthma-like syndrome. So, and the exposure need many years, 10 years, 15 years to 25 years. So the prognosis of the patient, They have a variable natural history. These diseases, it depends on the specific diagnosis, the cause, and the extent and the severity of the lung involvement, which is categorized by high resolution CT. So we do high resolution CT, we do lung biopsy, then we classify the patient lesion, the severity and the extent. Then we can, and the diagnosis, then we can put him as a candidate for being classified, and the prognosis can be estimated. Early recognition of idiopathic pulmonary fibrosis, for example, is very important for directing patient management and predicting prognosis. So a patient with idiopathic pulmonary fibrosis is detected early when the patient have only 2% fibrosis of the lung, not like the patient who is having dyspnea at rest, right? And idiopathic pulmonary fibrosis is typically progressive disease. So patients have a mean survival of 3 to 6 years. The earlier you discover the disease, the earlier you prepare the patient for lung transplantation if he if you cannot halt the disease, if you cannot stop the progression of the disease, earlier detection make you prepare the patient early. So it depends on the specific diagnosis, the extent and severity. The idiopathic pulmonary fibrosis have a mean survival of 3 to 6 years. Early recognition is important for directing the patient management. So sarcoidosis has relatively benign self-limiting course rather than idiopathic pulmonary